I would like to present the members of the team that have not presented so far. So Professor Zai is one of our radiologists leading the sarcoidosis studies in sarcoidosis. Thank you for that, Sujal. Professor Anand Devaraj is another member of our multidisciplinary team, also radiologist, with high experience in sarcoidosis too. And we have Professor Andrew Nicholson, who's also our histopathologist. And the main benefit from all this is that we are all sitting together, or we used to sit together in the same room, exchanging opinions about cases and their diagnosis and management, which is unique for everyone. I wanted to actually make a simulation of this meeting, because I think that this is for the benefit of the patients to understand a number of discussions that we are having in the backstage, and how difficult it is to have a clear management plan. Some of the questions raised over this session may also be answered during this meeting. So I will get on to present some of these cases. Also, just to say that we usually allow Athol and Sujal to exchange comments between each other.
We usually don't need much of an invitation.
I think the right word is insults, actually.
So the first patient is a 46-year-old gentleman who is an ex-smoker with a 5-pack year smoking history. He had a COVID infection in March of 2020, and then developed prolonged cough, breathlessness on exertion, and fatigue. His blood test showed mild lymphopenia. He had raised liver enzymes, for which he had an ultrasound of his liver. And his ACE was slightly elevated to 77 units per liter. This is not the right order, but I have given you the ultrasound of his liver, which actually showed that the liver was diffusely heterogeneous with a smooth contour, and the spleen was also diffusely heterogeneous. He had lung function tests that showed a gas transfer, which was normal. This was 91%. And he had mild airflow obstruction in his spirometry with an FVC and FEV1 of 127% and 84%, respectively. He had significant small airway obstruction, as is judged by his lung function profile. So, Sujal, I would like you to comment on his scan. This is the information that we have.
Okay, so I'm going to stop you sharing, and I'm going to share my screen. And this is patient 1, or patient A, as you've labeled it. I'm just going to enlarge it. Can everyone see that screen? I can see Elizabeth nodding, so that must mean they can see, everyone can see the screen.
Yes.
So what I see here is a relatively classical combination of findings, in that there is lung disease and there are some enlarged lymph nodes. We'll come to the latter later, as you might say. The radiological pattern in the lungs is that of essentially of nodules, and the nodules are, some of them definitely have a subpleural distribution. This is the fissure here, and the fissure, as we know, is a pleural structure. comprising 4 layers of pleura. Other nodules are very much in the sort of bronchocentric region, and that word bronchocentric is important. And other nodules don't really have a sort of distribution. They seem to be a bit random. However, most of the nodules are in the mid and upper zones, and that's another aspect of distribution that's important. So this is classical nodular parenchymal sarcoidosis, lots of micronodules. And then I said the lymph nodes were enlarged, and short of going on to a separate reconstruction, I can see roughly symmetrical hilar lymph node enlargement, subcarinal lymph nodes, and other mediastinal lymph node stations. So this is what you might call radiographically stage 2 disease. I don't see any signs of fibrosis.
So Sujal, can we draw you out into what I think will be the discussion point here? You look at this scan. Is there any other diagnosis than sarcoidosis that you think is sensible or plausible?
Not based on the imaging, but I suspect through a clinician's mind, a question, particularly if there's symptoms, a clinician's mind.
Just on the imaging.
On the imaging, there is no other diagnosis I would think of.
Okay, so now let me address this to the decision that you might be taking on whether or not to do a biopsy. Forget the medical jargon. We've heard that a very skilled leading international radiologist is unable to suggest an alternative diagnosis. So I see Elizabeth and I see Phil in the names there within our team, and I'm going to ask each of you to state a view, and please proceed.
So I think when you have this this type of very classical pattern for sarcoidosis, as Suja has described, with symmetrical lymphadenopathy, the micronodular pattern along the bronchovascular bundles, along the fissures, I would say that there doesn't seem to be the need to go for biopsy in this case. I don't know what the relevance of the COVID history and why, what that has to do with the case, but if we're going just on the imaging, I would be happy that this is consistent with a diagnosis of sarcoidosis, and that if the clinical features fit and there is no other concern, unless Suja is saying that there is something that worries him about this not being sarcoid, I think I would be happy to go without a biopsy.
And to ask Phil Molyneux to comment, would he share that view here?
I would completely share that view. The imaging is quite typical for sarcoid, and unless something in the disease behaviour over the coming months was to change, I wouldn't go for a biopsy at this point in time.
I think we have a fairly firm statement from 2 people here, which actually moves away from the historical approach. I suppose one is candid with the patient and talks through the likelihood being greater than 95%. Some patients will feel that if it's not 100%, they really want a biopsy, but I think most people have a sigh of relief. You buy into looking at this closely and you don't undergo an invasive procedure. The COVID is an interesting question. Elizabeth, you didn't provide an answer. I'll have a quick go. We know that COVID triggers a number of autoimmune conditions. That's one of the things it does. Autoinflammatory might be a better word. So it would maybe not be surprising with some of the inflammation pathways that COVID triggers if occasionally it turns out that it triggers sarcoid. I can give you a list of 6 or 7 autoimmune conditions that seem occasionally to be triggered by COVID. Okay, I don't think we think this is a post-COVID profile on the scan in its own right. Any other comments from the group at all, or should we move to the next discussion?
Prof, I have a question, we mentioned that this patient has mild airflow obstruction. He does have some raised hepatic enzymes. and he has the CT scan. On the basis that we have given him a diagnosis of sarcoidosis, would you treat this patient?
No, I most certainly wouldn't right now based on danger. The lung function reserve is excellent. We have very robust data now that when your gas transfer and key lung function tests are as high as this, you have to get an awful lot worse before you fall into a danger category. Now, make no mistake, this can be hard sometimes, but the lung function reserve is so great that I wouldn't want on danger grounds to subject this patient to immediate treatment with potential side effects. Obviously, if you have full inactivity, you must have cat-like observation. You've got to look hard, you've got to watch hard, and maybe quality of life will drive a treatment intervention. Elizabeth.
Yes, Athol, I was just wondering about the liver and the findings of the liver and whether they would require any further investigations. And we know that irreversible liver damage is rare in sarcoid, but can occur. Would that, what, you know, would we be?
Well, I think the issue here is that probably if you routinely biopsy the liver of every sarcoid patient, you would find evidence of, in inverted commas, liver sarcoid in 70+% of patients. A smaller group have some liver function enzyme elevation, but certainly in the liver world, the view is rather skeptical about intervening until you have quite a high burden of disease. And I think one of the issues, if you do get more severe involvement, is liver involvement by itself enough of a reason to treat? Now, I would not have said from this level of liver function disturbance that you've got an immediate reason to do that. We see too many patients who do have this in the first flush of sarcoid, and it does settle down. But it's something else you certainly watch closely, I agree.
And I guess I was going for the CT report, which I may have misinterpreted, that there were some abnormalities or irregularities in, but I may have, I didn't catch it well, whether there was any sign of major abnormalities on the CT, but there wasn't, Vasilis. Did I get that wrong?
We mentioned about abnormalities or some heterogeneity identified in the ultrasound of the liver and the spleen.
Okay, ultrasound, fine, okay.
You will get some variation in density when you have sarcoid involvement in the liver, but I don't think we're seeing anything that would drive us to risk poisoning this patient at this point. And I mean, if you're giving a drug with side effects that you don't need, that's not a bad definition of a poison. So personally, I'd watch closely and wait.
Okay, Sujal, I will move to patient 3 to allow Anand to give us a comment, because we may have to discuss less than the number of patients that I emailed you. So this is a very young patient, 35-year-old gentleman, ex-smoker with 10-pack years smoking history, who was given a diagnosis, who had a biopsy-proven diagnosis in 2015. He was referred to us 4 years later. When he was referred to us, he was on steroids 20 and methotrexate 12.5. He was oxygen dependent on 4 liters and was able to walk 50 meters on the flat. His blood test showed mild lymphopenia, raised ACE, and mildly raised D-dimers. BNP was normal. His lung function showed a mixed pattern with primarily restrictive, with an FVC of 58%, FEV1 53%, and a DLCO of 24%. I'm sorry, you're in front of it. Of 24%, yes. So, Anand, would you mind describing your imaging?
Well, patient 3, because Anand and I have opened up cases. I've opened up case 3. Shall I do it?
Yeah, sure, sorry, yes.
Okay. So patient 3 has got 2 studies. And
Yes.
the first study is from 23rd of July 2019. And I'm just going to scroll through so you just get a flavor of what we're seeing. So right down to the bottom, then go back up. And although the eye is drawn to the upper zone, so around here, where there is very marked bronchocentric fibrosis, another very striking feature of sarcoid is the way that the airways and the vessels are pulled backwards when they get fibrosed, or when there's fibrosis laid around them. And that's a sort of classical finding. So if you were to draw a line across here, the bronchovascular structures are pulled backwards. And that's a very telltale sign, I think, of sarcoid. Even down here in the lower lobe, this is the right lower lobe, again, there is very marked bronchocentric fibrosis with traction bronchiectasis and bronchiolectasis. But the rest of the lung away from that is also abnormal and comprises, and these lungs are of higher than expected density. And the reason we know that is if you compare the air inside those airways, you can see it's different. And the air in the lungs should be roughly, or not exactly, roughly equal to the air inside the airways, and it's not. So in other words, there's quite a lot of diffuse infiltration in the lung, quite aside from these areas of very, very abnormal fibrosis. And another sign which I think you sometimes do see is what I've started calling the reverse signet ring sign. And it often goes with this combination of very bronchocentric fibrosis, this posterior retraction. And then what you see is, as I said, the reverse of the signet ring sign, whereby the vessel is bigger than the accompanying airway. And whether that reflects pulmonary hypertension, I don't have proof for that, but it is something that I do see in sarcoid.
So can I briefly translate into English just a few things? The lung function shows that this is really nasty. The level of severity is quite a bit less than a third of the lung efficiency is left right now. Sujal, you're describing both very nasty scarring in places, but you're also describing something which is a good deal wider than that, which is not necessarily scarring. So I think you're saying there's a mixture of abnormalities here. Can I ask you, if you look at that scan, are you certain this is sarcoid, or are you actually more, it probably is?
I'm fairly certain this is sarcoid, because, and really it's because of these upper zone abnormalities where this very classical bronchocentric fibrosis and this posterior pulling back, which I think, you do see in sarcoid.
Now you mentioned something called pulmonary hypertension. That means potentially this is so severe on the scan and lung function that there is pressure on pulmonary blood vessels from the severity of disease. And shall I make one more point? When you actually translate all of this, you are need to look at treatment fairly urgently, right? And we'll come to that in a minute. But this does mean that you have to be that much more secure about diagnosis if you're going to be embarking on a fairly heavy duty treatment based on the diagnosis. So let's, Vasilis, continue.
So my question is, you've answered, I think, the first question, whether the patient needs another biopsy. Do you need any further tests before deciding as to whether this patient requires any change in management?
And again, I think this should be put to other panel members. So Elizabeth, Phil, please express a view. And
yeah. So basically, as Suja was mentioning, the reverse signet ring sign, so looking at the vessels, they seem enlarged compared to the airways, whereas there should be the same diameter. The pulmonary artery, it was bigger in diameter than the aorta, another suggestion that there could be pulmonary hypertension. And we saw from the lung function that the KCO is significantly reduced, which is a lung function parameter, which in the absence of emphysema could suggest pulmonary hypertension. So I would want to look at non-invasive measures of pulmonary hypertension, such as an echocardiogram, BNP levels, a 6-minute walk test to look at the level of oxygen desaturation, and then decide whether actually this patient needs a right heart cath to measure more precisely the level of pulmonary hypertension. And that's because in sarcoidosis, we know that at least for some patients, the treatments for pulmonary hypertension can help.
Okay, right. Please proceed. Or unless Phil has a comment.
No, I would agree. I would not be doing any further biopsies here or anything else. The radiology is convincing, along with the serological tests.
And biopsy might be rather dangerous here, I think we'd agree.
A biopsy would add little and provide a lot of risk.
So Elizabeth, the patient was already oxygen dependent. His echocardiogram and cardiac MRI did not reveal any signs of pulmonary hypertension. He did desaturate when walking, had severe gas transfer impairment. So a decision about treatment?
Again, my colleagues, so I'm not sure if Peter George is with us, but again, Phil, perhaps you go first on this, Elizabeth, you follow.
So at this point, I think the initial therapies likely to be more aggressive with a view to trying to get on top of the disease as quickly as we can. If there's any kind of reversibility or major improvement we can make, we want to do that straight away. So rather than the last case, which was watchful waiting, this is almost the opposite, where we're dashing in to try and make some change. So that would probably be with steroids and with a second-line immunosuppressant right at the start. So methotrexate, we may add in some pulsed steroids to try and really kickstart this. That would just be a discussion based with the patient, really, what they wanted. But I'd certainly be going on with 2 drugs right at the beginning to try and maximize any benefit.
Any comment, any addition to that, Elizabeth, at all? We seem to have studied silence.
Yeah, no, sorry, I was muted. So I agree with Phil. I think you would want to see in the quickest way possible whether there is still some reversibility. And sometimes the only way to do that is to treat intensely and IV methylprednisolone, so a drip treatment with very high doses of steroids just for 3 days, followed by a tapering dose of oral steroids, is the quickest and probably the safest way to do that, and to see if there is reversibility and the degree of reversibility, and that would represent your new sort of aim to maintain in terms of, for example, lung function.
The main challenge was that this patient was already on steroids and methotrexate.
Yeah, I heard that about the methotrexate. You would probably still want to, but of course, we can hear what the others think. He was just on 10 milligrams, right?
He was on 20 milligrams of steroids and 12.5 milligrams of methotrexate. And just for the interest of time, we did perform a PET scan on him.
Very good point, yes.
Yeah. But just to say, I mean, at 12.5 milligrams of methotrexate, that would have been increased straight away, and probably still a pulse of steroids on top of some oral steroids would have probably been our first line therapy while we wondered about either switching off methotrexate or adding in other immunosuppression. But I still think we would have gone with a pulse of steroids and a rapid escalation up towards 20 of methotrexate.
But I guess the PET, I agree with that, but I guess the PET would be useful, wouldn't it? Just to show whether there's still activity, yeah.
So just to say that we did the PET, we gave him IV steroids, just to show you very quickly. So we did the PET, which showed some activity within the lymph nodes as well as the fibrotic areas. We did give him IV steroids, but the main challenge was, and we referred him for transplant. The patient, this is his serial lung function test, where he had some response originally in DLCO values, but then went back to similar levels, 25% of gas transfer values, and his FVC continued to decline. The patient was rather disappointed by what was happening, and he stopped treatment altogether.
So Vassilis, it is possible the treatment slowed or arrested decline rather than achieving a response. We'd accept that much. But you're now taking us to transplant, I think.
Yes, and I'm now taking you to, he had a repeated PET that showed increased activity within his lungs and fibrotic areas that I think was the main reason for reinstituting therapy. So even in a patient who has end-stage lung disease, high level of immunosuppression didn't really help, but it did stabilize things. So we need to comment on whether treatment in fibrotic patients is actually achieving improvement or what is the target there. I will leave this for you to comment.
Well, what I would say is that in areas of scar tissue, if you don't have PET signal, I'm not clear that the treatment is likely to achieve much, but we're not yet at a stage we can use PET exactly like that, I don't believe. And I think most of the time we hope for response, and we often in somebody in this situation hope more for stabilizing things and giving us more time. And sometimes a small improvement is a very big thing if somebody is really on the edge of their reserve. So even small gains can make all the difference in the world on all sorts of levels. So I would not routinely at this point use PET to drive the treatment approach, but I know that there's a lot of variation in that around the world.
The main reason for using it was the fact that he stopped treatment. But the important bit comes next, which is January 2021, when the patient is transplanted. And Sujal will show his current scan.
So this scan I'm about to show you is from 21st of January of this year. So these are the new lungs, as it were. And clearly we don't see all that abnormal disease that was previously present. There are some pleural effusions, I guess, only to be expected. There are small pneumothoraces. Again, I presume this is relatively recently transplanted because there's also an indwelling catheter on the right hand side. So this must be immediately, well, not immediately, but in the relative immediate post-operative or post-transplant period. There are small effusions. There are some thickened interlobular septa, probably representing a degree of interstitial edema, but clearly a new set of lungs.
Yeah, I must say that the patient is off oxygen, as you may imagine. Yes, he's using medications, but he's very well. You can see that, of course, he's very young. He's 35 years old, but he has done remarkably well post-transplant. We're very happy for him. In actual fact, I think looking in retrospect, we may have actually given him treatment to bridge the time of his presentation until transplant. But, you know, it's a lot of discussion around that issue.
Well, that's, if the patient was describing worsening breathlessness in the time immediately before coming to us, and then you see there's a period of complete stability on lung function, I think you've got as a fair bet that maybe the therapy has at least temporarily bought some time. Now, that's all I would say about that. It's a fair assumption that it's quite probable.
Would you mind staying for having one more? Let's do patient 4, just because of the interest of time. I know that everybody's very busy, but I think it would be nice to do this patient too. So patient 4 is a 42-year-old lady, non-smoker, who was referred to us in 2020 due to cervical lymphadenopathy and systemic disease symptoms. She was also diagnosed with fibromyalgia 6 years prior to referral, and she was on painkillers. And her blood test showed mild lymphopenia with normal ACE, no other significant abnormalities, mild iron deficiency, but everything was normal. Her lung function showed a gas transfer of 73% and a normal normal spirometry with FVC and FE1 109 and 113% respectively. So we would like to hear the comments on the scan.
Thank you, Vasilis. Can you see the screen?
Yes.
Okay, so this is the scan from 2019. I'll just go up and down. And what this shows is abnormalities mainly in the upper lobes and apical lower lobes. And what we see are these multiple small nodules, which are centered on airways. And in some areas, we also have larger confluent nodules that are forming consolidation. The distribution of the nodules is in a very typical distribution for sarcoid, situated along the vessels and airways. And those nodules represent what we call granulomas or granulomata in the lungs. At this stage, there is very little evidence of fibrosis. Maybe there are some dilated airways up here in the left apex and right at the top of the left lung, but most of this you would say is potentially reversible, and the lower lobes are completely clear. I have one more scan, but let me know when you want to look at the follow-up.
Just to ask you a couple of questions, do you entertain any diagnosis other than sarcoid?
No, this would be so characteristic of sarcoid that there would not be any other diagnosis. Okay,
and you said very little scar tissue. If you look at the overall burden of disease, taking everything aboard, how would you say rate the badness of the disease on the scan?
So the fibrosis component is maybe 5% at most, which is very limited. The rest of the abnormalities, even though they are affecting maybe 30–40% of the lungs, the top and middle, if you like, they are, in terms of severity, potentially less clinically significant, potentially more reversible. But of course, that can vary from patient to patient, and you'll need to correlate that with the lung function. But so in other words, even though there is quite a lot of disease, it's potentially quite quiescent and reversible.
Yeah, the lung function indicates what we would call minimal loss of lung function. And we'll be asking further management questions. The one thing I would say, this might be only 6 inches deep, but it might be a mile wide. In other words, it may be that if 30–40% of the lung is involved, you've got to watch rather closely how this develops and come back quite quickly to looking at the behavior of the illness. Anyway, Vasilis, please.
So the patient wanted the biopsy to be 100% confident, especially because of the size of the cervical lymph nodes, and this was obtained and showed non-caseatic granulomas, and was rather reluctant to take treatment. So she prepared a watch and wait approach, and she is coming back.
She's coming back for review. So
yeah, I'll have that. Sorry. So she's coming back for review approximately 9 months later. She has had lung function in the interim. And there is a slight decline, I would say, stability in gas transfer values, 72%, but a decline in both her spirometry and in both spirometric values. Both of them are within normal range, so the significance of them is to be considered. But she had a repeated scan also as part of monitoring her condition.
Vasilis, can you hold that on the screen, because some people will see 6.2 becoming 5.94 and they'll say, what is this? You've actually got an obvious drop in the number with time. I'm looking at TLCO corrected, which is 6 up from the bottom. But what we do know is that these tests have noise of measurement, and a third of healthy individuals will have that sort of variation when you put that test and you repeat it, say, 4 weeks later. So this is stability because it lies way within the variation of the test. So don't be fooled by the exact numbers. So Vasilis, please keep going.
I will hand back to Anand to comment on the latest scan. Which is, I think, 18 months apart.
Okay, so the scan on the left of the screen is the follow-up scan. The scan on the right is the one I showed you a few minutes ago. Just to recap, I'll go up and down. But what we can see has happened now on the scan on the left, which is a little time apart, as you say, is a couple of things. First of all, there are now very numerous nodules affecting all the lobes. Previously, the lower lobes were clear, but now we see all of these tiny nodules, these dots, indicating that the sarcoid has involved more of the lung than it did previously. But also importantly, we're starting to see more fibrosis, which we know has the scarring that has set in because the airways are dilated. That's the sign we look for on CT to look for fibrosis. So this is progression of disease, both in terms of more fibrosis, but also in terms of more new non-fibrotic sarcoid.
So let's just talk through what is sensible at this point. I've bullied my colleagues on management to this point, so I'm going to let them off and say something quickly and let them agree or disagree, I think. This really is, in terms of lung function, still just 6 inches deep, but on the scan it really is a mile wide. And the risk is that if the tide comes in, it becomes more severe, it will come in with a vengeance. And we will be seeing something very severe developing. You've got the clue that scar tissue is now forming, the word fibrosis meaning always scar tissue, which won't be reversed. So I don't think anyone is going to sit on their hands at this point. But can I now turn to Elizabeth and Phil and ask them exactly how they'd manage, what they'd introduce. Please go ahead.
So I would agree, I completely agree that you wouldn't want to sit on this. There has been a loss in spirometry, which although not great, is about 10%. The gas transfer was stable, but her spirometry is coming down. And the CT in this case is much more suggestive of a major worsening with now scarring. So we've heard this morning from Anjali that we don't tend to use as high doses of steroids for as long as we did before. So you would discuss with the patient whether she would be willing, I mean, you would be now treating to avoid danger to the lungs, danger in the sense of irreversible damage to the lungs caused by scarring. So we are no longer having a conversation about quality of life, but we're having a conversation, as with your subdivision, about the need to treat to prevent irreversible damage and to gain back any lost lung function. So if she is agreeable, I think my first option would be to go for a reasonable dose of prednisolone between 20 and 40, probably around 30, for a month or so, and then start reducing and seeing how she responds to that. If for some reason she is very reluctant to go on sarcoidosis, or there are other issues, one might introduce from the start a steroid-sparing agent. But I'll leave Phil talk more, but I think that would be my option to begin with.
Yeah, thanks, Elizabeth. I think I probably tend to use more steroid-sparing agents from the start to avoid steroid side effects. So, but it'd be a decision down to the patient, and I'd give them both options because we have a little bit of time here to slowly build up therapy. So there would be an option of going on methotrexate and building it up over a few weeks, as opposed to the last case where we had to go in all guns blazing. So I think given the side effect burden of steroids, I'm more and more seeing a benefit of going straight onto methotrexate, given that the majority of patients do tolerate it. But it would be up to them at the end of the day.
I think this case illustrates three separate views on management, and that does show us that actually a lot of the time we do have to act beyond hard evidence. So personally, I would say that a short, sharp pulse of steroid might actually deliver a dramatic response and establish very, very quickly that low-dose therapy is enough. Now, I'm saying that because the huge bulk of the abnormality looks very reversible right now. And my worry would be that if you don't find out fast that you can manage this with very low-dose therapy, and if you don't find that out fast and you kick at this with less definitive treatment, you actually end up not in the first 10 days, but over a period of months with a greater treatment burden. So to me, this seems like a case for post-therapy, a very quick reduction to say 20 milligrams daily, a further quick reduction, perhaps a week or 10 days later to 15 milligrams daily, if there's a striking response. And I'm really saying that because so much of what is extensive looks nodular and reversible. And I don't think I'd feel that way if there was a lesser reversible component to this. But I think the three of us can agree that no one of us is correct about this. And I think the important point I suggest is sitting down and discussing it with the patient and talking through whatever patient preference there is for steroid dose. Do either of you have any more to say, though? Do you accept that there's really division on what we might do in this case?
I'd be happy with all three of those plans. And, you know, pulse steroid involves 3 trips to a hospital. Methotrexate without steroids, you know, can have some more side effects. Steroids alone have side effects. So I think all three of those would achieve the same outcome ultimately. You may find out slightly quicker with the pulse steroids, but I think I'd be happy with either three of those.
Okay, Vasilis, do you want to have a casting vote? Because you've opted for 3 options, so anything you vote for becomes the official view. Or are you?
I will just, I don't know the result, but I will just say what was the patient's choice. The patient's choice was with Elizabeth.
Yeah, so that means Elizabeth is correct.
I don't know, well, how did she do? How did she do?
She's currently on treatment.
So you're saying that she's changed her mind and she's accepting therapy is the start of right sort of outcome?
Yep.
Okay.
I definitely want, I had asked both Sujal and Anand, and I know that they will be frustrated to work up 5 cases, but it's more the the discussion that is created as a result of those that is very interesting for the patient and everyone, I would say. I think that we need to bring the MDT to a closure, I want to thank you, all of you, for participating. It's a major plus for the patients. Thank you all.